Thank you everyone for logging in to our Wellness Wednesday live webinar. This is a platform focused on health and wellness with guest speakers and specialists answering your questions about physical and mental well-being. My name is Zarmina and I'm delighted to be on this journey with you today. Please help me welcome our guest speaker today, Dr. Ignace Janssen, a laparoscopic and bariatric surgeon in the Netherlands. He has developed the biggest bariatric center in the Netherlands with over 1,200 patients a year and is a CMO at the Dutch Obesity Clinic, which has developed a value-based healthcare program for bariatric patients. In 2018, through a strategic alliance with Medtronic, they opened a Curo clinic in Dubai and Abu Dhabi in collaboration with NMC Hospitals. Thank you so much, Dr. Ignace, for being here with us today, and welcome to our platform.
Thank you very much, and I'm pleased to be here, of course, and I'm looking forward to answering questions about bariatric surgery.
Well, it's great to have you. I know we have a lot of interest and questions in this topic, and you've kindly prepared a presentation as well. So we will have that pulled up onto the screen. I would like to start with asking you about obesity in general, Dr. Ignace. Obesity is recognized as both a chronic illness and a serious health issue. Curo Obesity Center is dedicated to fighting morbid obesity and offering life-changing transformations. Can you tell us what this means and what do you do?
What we do is, of course, around lifestyle change, around an operation. And that means that we are specialized in helping people who are morbid obese. And if you look here, this is the team we are working with in Abu Dhabi, and in the center is our surgeon, Dr. Bart van Wagensveld. So what is different that we think than most of the other centers are really saying, this is the surgery and the surgery will help you and you will be cured of your obesity. But we know the surgery is very important and we need the surgery if you are morbid obese to get this big change. But to keep your weight down after losing your weight, you will need to change your lifestyle. And this is very difficult. And this is why we have this team to help you to change your lifestyle. And we do this till 5 years after the surgery, because mostly people reach their lowest weight at 1.5, 2 years after surgery, and then it gets difficult to maintain the weight loss.
That's such a great point, that it's not just the surgery itself, right? It's not entering the operation theater and then leaving it and thinking that's my solution. It's actually a journey. And you mentioned a period of 5 years. Is there any particular reason that you say 5 years?
No, it's actually not. But if we look at people, we know that after 2-3 years, there are more people who are getting weight regain. And that's the moment they need the support. And mostly after 5 years, they come in a stage which is easier to have control and to maintain your weight. So we want to have the most difficult period covered. And that's why we take those 5 years.
That's great. Well, Dr. Ignace, from studies show that around 40%, the UAE's obesity rate is double than the world's average, resulting in a significant increase in obesity-related healthcare costs. To put this into context, could you share what are the medical conditions related to obesity?
Of course, and here you see a slide and it says comorbidities of obesity. And if you go on the left and go down, you see first the influence on your brain. So you have more migraine, depression. Pseudotumor cerebri means that the pressure in your head is rising and then you get headaches. And it's all because of the obesity. If you look at your lungs, that's the next point. A lot of people know that you can have sleep apnea, And the sleep apnea, this is causing you at night that you are not getting enough oxygen in your body. You are breathing not good enough, and then you get awake and you breathe well again. But if this happens all the time, you don't sleep well and you get very tired and sick. So, and this changes if your weight is normal again. Your liver is not used to all this fat, then you can get a fatty liver. And actually, if this proceeds, your liver will fail in the end. Very well known is the diabetes. Diabetes is very correlated, diabetes type 2, with overweight. We come on this later. With the female, you have the polycystic ovarian syndrome. This means that the female, this is one of the reasons why they have difficulties getting children, and saying females or pairs who don't get children, 30% the reason is overweight. So this is the fertility is a very big problem. Now then you have problems with the veins, so the blood going back to your heart, it's developing all white veins in your legs. So, and you see here a lot of different things going to the incontinent because you cannot keep your urine well. One of the most things happening is that you have problems with your knees. Your knees are getting very painful because they have to bury the weight. And I come back in the next slide to the cancer. Can I have the next slide? Probably, I think I didn't know this in the beginning myself, that overweight is associated with a lot of different kinds of cancer. And actually the chance of getting those kinds of cancer is more than 4 times normal. So this is really amazing. And you see here, this is all kind of cancer. And if we look at people who are operated and getting a normal weight and comparing this with people who are not operated, after a couple of years, you see that operated people live longer. And if you look why, that's because of the cancer. They won't get so many cancers as the people who stay on this very high overweight and get easier ill.
I see. Well, there are a lot of, you mentioned a lot of the comorbidities of obesity. Can you share with us the different surgery options available? There's so many positive outcomes of that surgery. And also, how do you know if you are eligible for those options that you can share with us?
Yes, I have here, the first slide is the most performed surgical procedure. If you look at the top, then there is the esophagus, we call it, and you come in the stomach. And the sleeve, then you remove 3/4 of your stomach. And you get just a small part of the stomach is left, and which causes that you cannot take in so much food. And the food which get in passes quickly to the small bowel. So this looks very simple. It is not a very difficult operation, but you have to remember it is not reversible because you remove 3/4 of your stomach and you can never get it back. Next slide, please. Then the second most done operation is the gastric bypass. You do not remove anything there. And like the word bypass says, that what happens here is that the food, if you look at the red arrow, that's where your food is coming. And we make a change that the food is coming in a small, tiny part of the stomach, which is called the pouch. And from there, it goes to the small bowel. And the remaining of the stomach stays in the body. And later on, the juices from the gall, from the liver, and from the pancreas. They come in, and that's the green arrows, and they come later on together, and then we say that's the common bowel, because there the food and the digestive juices are joining again. And this gastric bypass is a little bit more difficult to perform, but gets a little bit better weight loss and longer standing weight loss. And we advise it because it is much better in not curing, but making the diabetes better. So we advise this in diabetes patients. Next page. Then later, this is just for the latest 8 years, it's already on the market, but that's a new variation. It's called the one anastomose gastric bypass or mini bypass. And you see here on the right that you make a very long pouch, and that you just make one connection instead of two with the bypass. The difficult thing here is if you look at the green arrows, you see that the digestive juices come together at the point where the pouch is, and they get into the pouch also. So this is one of the problems of this new operation, that you get the bile in your stomach, and your stomach gets ulcerated by this. So that's about 20% of the people. You have to change this to a normal bypass.
Okay.
Next. If you have the SADI, this is a single anastomosis duodenal ileostomy. That's a big word, but it's used for people who have sleeve and who had a lot of overweight, and sometimes they need a second stage operation. So if you look at the arrows coming from the top and going down, you first come in the sleeve, and then you see there is a connection after the pylorus, which is the valve of the stomach, and you come in the duodenum, which is a small bowel, and there you make a connection with the lower end of the small bowel at 3.5 meters before the colon, which is the last part of the bowel. Mm-hmm. This really gives you much more weight loss, but also you have to go frequently to the toilet, and you have to really check every half year your vitamins, because the chance of deficiencies is very high.
I see. And so with these options that we have, so there are a lot of, options for individuals, and, the right surgery is matched to the right individual based on their criteria. But what is the role of bariatric surgery in treating diabetes? And would you say that bariatric surgery is a cure for diabetes?
Now, I would not say it is a cure, but it improves diabetes a lot. So if you look at diabetes, actually it is a chronic disease. And it means that over time it gets worse. So it depends on at what time you will be treated by bariatric surgeon. If you have diabetes no longer than 5 years, most of the time you will have a complete remission. That's 64%. Because then you will go back in time for 10 years and you don't need any medicines anymore. It doesn't mean that if you go older, that maybe you get again diabetes, but that may be much later. So if you have diabetes for over 5 years and using insulin for over 5 years, the chance is getting very small. Then mostly you improve. You have to use less medicine to get a good result. But if you have over 10 years long diabetes with insulin, we are pretty sure that we are not able to get all the medicines away. So yes, you will improve, but you will not be cured, and you still have to use some medicine to regulate the diabetes.
Thank you. That's very helpful and sheds a lot of light on the role of bariatric surgery in treating diabetes. Dr. Ignace, can you share what are the side effects of bariatric surgery that one should be aware of?
Yeah. If you have an operation, there is no operation without problems. And so also with the bariatric surgery, you can have some problems. So I have, first of all, to get a feeling of how dangerous bariatric surgery nowadays is safer than a gallbladder surgery. And we do this a lot, and everyone thinks, okay, there's no problem, that's easy. So it's actually a very safe operation, but still mortality is 0.1%. That means that 1 in 1,000 patients operated can die from the operation. Okay. And serious complications is 2.3%. And this is about the complications in the beginning after the operations. And the most important complication is actually bleeding. And that is because you cut a lot of tissue, and then you can have a bleeding inside, that the blood is going through the digestive system, and actually it comes out by going to the toilet. Mostly this stops by itself, or otherwise you have to ask the gastroenterologist to look and place a clip. Mm-hmm. And the other possibility is that's bleeding inside the stomach, inside the abdomen, and then sometimes we have to reoperate. That is the most common. Sometimes you have leakage, but it's very seldom. If you look later on in life and you look at the top, you get more chances of getting gallstones, but they say about 10% of those people get gallstones after the surgery. But if you look at the same people who don't have surgery, 6% gets a gallstone. So you have a bigger chance of getting gallstones. Mm-hmm. Small bowel obstruction, that means that after every operation, but especially after the gastric bypass, you get that the small bowel is on a different position and can rotate around the position where it's connected. And then it kinks and the food cannot pass, and then you have an obstruction, and you have to look in the abdomen to make this better. And that is about 2%. And gastric ulcer, that's also special in the gastric bypass, but also after the sleeve. And that's the reason why we give patients half a year long PPIs, that's reducing the acid in the stomach, and then the chance of the ulcer is very low. One of the problems is abdominal pain, that especially after the bypass, a little bit more than after the sleeve, because the different location, and we don't know exactly why, but people sometimes get more pain in their abdomen, and sometimes it's just because the passage of the food is going difficult, and this causes pain. And we cannot always have a solution for this. Reflux, that's especially that means that the acid from your stomach is coming to your mouth, and this is especially worse for the esophagus, and this is especially a problem with the sleeve. So because there is such a small stomach, so there's such a small stomach that the acid is easily coming up. And the last thing is the kidney stones. You have a little bit more chances after the gastric bypass, and very important, the deficiencies, also the sleeve and also the gastric bypass patients. If you use the tablets you get advised daily after your surgery, the chance of deficiency is very low. But a lot of people think, oh, I feel very well, so I don't need these tablets anymore, and they stop. And then we know 80% is getting those deficiencies. So please use them. If you think I do this operation, you have to use these vitamins your lifelong after surgery.
Well, thank you so much, Dr. Ignace. That really highlights a lot of, let's say, complications or maybe side effects just to be aware of when undergoing the surgery. And obviously, the process itself is not a simple one. It requires a very skilled experience and is very invasive. So there are people who say surgery is the easy option, and I think that we need to maybe have a conversation around that. It doesn't really sound very easy at all. What would you say about that?
No, and I have a slide here. This shows a little bit that obesity is very difficult. So in the center is actually why are we obese? And you see there are a lot of connecting lines, and you see also all the locations. And this means that the obesity is influenced not only by yourself, but a lot by your genes and your environment and how the food is getting to you. So it's very difficult. People always say, oh, just do a diet and move a little bit and the problem is gone. But that's not true. And the other hand is, if you do surgery, you actually get a reset of your body, and your body gets used to a lower weight. And then it's easier, but not simple, to maintain this lower weight. And to maintain this lower weight, you actually have to change your lifestyle too. May I have the next slide? This is also showing a little bit of the overweight, and if you want to eat and if you are hungry, that's all in your brain. And we think that's only obvious that that's what you think of, but it's a lot of the hunger and the satiety is because of the feedback your brain gets from your bowel and from your stomach. So if you go lower, you see a big arrow, and it calls the endocrine systems. And this influences, for instance, the diabetes, which improves after the surgery. But also in top of the lower is the ghrelin, and the ghrelin is a hunger hormone. And after the sleeve and the gastric bypass, this hunger hormone gets on a very low level. So that means the will of your body to eat gets down and makes it easier.
Mm-hmm. So that is very helpful, and thank you for sharing that. So it is a big decision for somebody to decide or be eligible for this surgery. What does the aftercare of the patient looks like for those who are undergoing the surgery? What is the full treatment plan? You mentioned it goes well beyond the surgery itself. What does that journey look like?
Can you share the next slide? Yeah. What we try to do here, and don't look at the text, but only at the science, is also that we put in what's of influence of your weight. And of course, if you look at the first quadrant is about moving and what you do at your work, and if you do sports, what people forget is you need to sleep and you need to really have a regular life. So if you, for instance, people who have to work at nights have a much higher chance of getting a higher weight. So this is a part of and the physiotherapist, but also the psychologist to look at what's helping you. If you look at the diet as the next thing, then you, of course, one of the problems is the alcohol or the drinks. The soft drinks are full of sugar. So look at what you're eating. And if you look at what you're eating, you also have to look at what you're buying and if you're actually cooking. One of the problems nowadays is that a lot of people don't cook themselves anymore. So they eat a lot of prepared foods, and actually those prepared foods most of the time are not so good for us. They have a high level of fat and sugar and salt in it, and they are actually unhealthy. So it's better to cook yourself, or to be sure that if you go out to choose the right restaurants. Mm-hmm. If you look at the next step again, if you are operated and go back, but at the lower quadrant, I would say, there is the image of your surrounding. Because if you want to change your lifestyle, you cannot do this without the help of your family, of the people next to you. So this is also a point where we need our psychologists to talk with you. If you want to change, it's impossible to change only yourself, but you have to ask your family to do the journey with you, because it's healthy for everyone. And not thinking, sometimes people think, oh, I do it, and all the others, they do it still the same. Now, that's not working. So you see that we have someone who helps you with moving, that's a physiotherapist, someone who helps you with the diet is a dietitian, and also a lot of people need psychological help to understand what you need to change your lifestyle. The next quadrant is also telling you, because people sometimes, if you get depressed or are in stress, a lot of people start eating to solve this problem. And then you have to change this connection too. Also, one of the things our psychologist helps you to change this relation between the stress you get or the depression you have with your eating habits. Now, and the top quadrant is a little bit just about what's in yourself, and you cannot change this so much. This is what you get from your parents, except for the medicines. We also look always at what medicines are you using, because a lot of medicines cause overweight. But we start to look at before the operation, of course. The next slide, please. This is already what it helps the next question.
Yeah, so that's great. It gives us a full picture of how it's a 360-degree lifestyle impact rather than just in and out surgery. And you mentioned a few key roles. You mentioned mental health, and at the start, you also showed a picture of your multidisciplinary team. Can you share a little bit as to why is there a need for a multidisciplinary approach to bariatric surgery, and what are the other key roles in this journey, such as you mentioned a psychologist, dietitian, etc.?
Yeah, we think that we know that if you want to have the surgery and you think the surgery will solve everything and I don't have to do anything, the results on the long term will be poor. So we know that you have to be prepared. So we use our multidisciplinary team to talk with you about before the surgery already. Please look with us. What are your problems? Do you know yourself? How you want to change? What you want to change? Why you are on this weight? And how you think you can help yourself. So, and we think that the surgeon is the best in doing the surgery. The psychologist is the best in looking at what are the psychological problems and how can we help you to look at the problems to solve them. And of course, the dietitian, we need her a lot, because you have to change your eating habit. It's impossible to eat normal after the surgery, but after half a year, you can eat more, and she needs to guide you how to change your diet on a good way so that you will have a healthy diet on the long run. And also actually at looking at how you are moving and doing sports. A lot of the time you don't have to do sports, but you have to walk or do something. And that's what our physiotherapists are specialized in, to look at you. How can you get this into your daily habit so that it's not something that's very difficult and you do for half a year and then you stop, but no, get a new habit of moving now. So that's also why we try to make groups, that you talk to other people who have the same problem, that you get support of someone who understand how difficult it is. And so we also have this group support. And yes, we think that not the surgeon, but just those specialists in training all those things can help you the best. And that's why we have this whole team guiding you before and after the surgery.
Thank you. That is so helpful and gives us a full picture of this journey. I'd like to ask you one last question before we jump into our audience questions. How does weight loss surgery affect overall health? Ultimately, how does it change your life?
Now, if you look at changing your life, you see a picture here of how different people get. So that's really in this first year, they change so much, and this really improves a lot. So if I go back and look to figures of what it means in quality of life, one slide back, this was, let me see, there was the quality of life was standing there.
Yep, I think this is the graph.
This, yeah. What you here see in the top is the quality of life. And if you see the black dotted line, that's what people tell you after surgery, 1 year after surgery. They say the life changes from a 4 to 9.5. So this is incredible. So the change in this first year is really dramatic. If you look a little bit at the longer run and you see the dotted blue line, this is the physical health. And you see that it comes from just above 50 and rises to above 80. And then slowly gets a little bit less over the years, but still a lot better physical feeling in the quality of life. If you look at the mental health, it improves the first 2 years, and then it gets down to a level a little bit above the level before the operation. So we know now that people who are, for instance, have a depression and they think, if I lose my weight, I will not have any problems with my depression anymore. That's not true. So that's also a little bit inside of yourself, and not everything changes with a better weight. But if you look at the quality of life, overall, it really improves, and improves also a lot at a long time after the surgery.
That's great. And there's so much optimism in that. And thank you for walking us through that presentation. There was a lot of information you've shared, and I know that was very helpful for our viewers. We do have questions that we can jump to. Just to remind everyone, please feel free to submit your questions in the chat box or in the comment section. We will definitely be able to get to them with Dr. Ignace. So let's take our first audience question. And I think this is a great one to start with, and probably we have quite a few people thinking this. Why do people regain the weight after surgery? Is there a common reason or explanation for this?
Yes. It's a little bit that your body is getting adjusted to the new situation. Mm-hmm. So if you look, for instance, what I showed on the picture at the common channel, that's the part where the food is taken in. And we know that the capacity of this part of the bowel increases and is better in getting everything out of the food. So you get an adaptation to the new situation. Also, there is a difference that the operation is not working with every person as good as one at the other, because, and we can also see this if you look at the endocrine hormones in your body. I told you about the ghrelin, for instance, which is getting down after the operation, and that's not with everyone. And some of those hormones you see rising again after the operation, and then you know that the influence of the operation is getting down. So one is this, that the influence of the operation is getting less. The other problem is, of course, that if you think that you can just go back to your old life and eat everything you want, then we are sure your weight gets up. So you have to also maintain a little bit of life change there. Otherwise, it's not working.
That's great. Thank you. That clarifies a lot. We have another question, also a very insightful one. Is BMI, body mass index, an accurate indicator? I'm guessing an indicator of being in the healthy range. What would you say about that?
Now, actually, it's the best and the simplest we have. So people say the circumference of your abdomen, for instance, is a better parameter at looking how bad the overweight is for you. But your weight and your length are very simple to get. And we know there is a good correlation between the BMI and how healthy you are. But it's not the best parameter there is, but all the others are more difficult to measure well and to compare to each other. So we still stick to the BMI.
Okay, great. And just to add to that, just for maybe some clarity, is the BMI an indicator used for all age groups, or is it just for specific age groups it's more accurate?
It's actually for all age groups, but with children, it's different because they grow and then the BMI is not so accurate. There they use the growing curves and how much they differ from their curve. So that's different.
Okay, great. Next question, a little bit contradictory. Is it possible to be overweight and healthy? My take on this question, just to share with you how I understand this, is I think in our environment lately, we're seeing a lot of acceptance of plus size, whether it comes to modeling or just lifestyle decisions. Is that possible to fall in a typically overweight category but still be healthy?
Yeah, there's a lot of discussion there because there's a lot of research at I would say I would compare it with smoking. We know smoking is bad. We know that your chance is 10 times as high to get lung cancer, but everyone knows someone who get 90 years and had smoked his whole life. It's a little bit the same with overweight. If you have a lot of overweight and you measure in your blood, you see that even if you don't have hypertension, diabetes, and we call you healthy, but in your blood you can see that your body is actually higher on stress hormones. So you are a little bit, for instance, now with the corona, you will more easily get the corona. So you are vulnerable. And this is, yes, you can old with overweight. A little bit overweight, we know, is actually not so bad. So till a BMI of 30, no problems. But on the other hand, a BMI above 45, we know it's not healthy at all. Okay. And a little bit else there, it's also a little bit depending on the race. So are the Asian people and Hindustani, they get at a lower BMI, they have diabetes and they get ill and have those comorbidities at a lower BMI. This is also depending on your background and your genes.
That's very interesting. Thank you for sharing that. You mentioned genes, and that's the perfect timing. We have the next question, specifically on gout. Is gout genetics through my family, having gout? I think that's one of the points that you mentioned, one of the comorbidities that you mentioned earlier on in your slides.
Yeah, the gout, I am not actually sure if it's the genes you get it, but I'm sure you have more chance of getting the gout if you have overweight. So it's related to the overweight and not only to genes.
Okay. And talking about this relationship to overweight, we have a question on fertility. What is the relationship between obesity and fertility? I think you mentioned polycystic ovarian syndrome early on in the slides. Is there a correlation that we can identify with fertility in general?
Yes. One of the things which a lot of people don't know is that the fat actually acts as an hormonal organ. So it transfers, and it's not only for the female, but also for the male. So if you look at a male person who is having a lot of overweight and you look at his testosterone will go down and his estrogen will rise. And that's because it's transferred in the fat cells in your body. So, and this also with the female. So this fat has influence on your hormones, which are responsible for your fertility. And that's why this overweight is of a big influence on the fertility.
Okay, great. That sheds a lot more light on that. Our next question is referencing something from your presentation. You mentioned that cancer is 4 times more occurrent if you are obese. Does obesity trigger a gene for cancer, and is chemo while obese effective?
What people think is that if you look at the reason why you get cancer is that all people have cells which turn wrong, but your own body takes them away. So the capability of your own body to know which cells are wrong and take them away, that's very important. If you have overweight, your I already told that the how do you call it, the cells who deliver this resistance to wrong cells, but also to infections, they are in the wrong status. So they are not so effective as normal. So it means that you are more vulnerable to infections, but also less capable of removing the wrong cells. And that's probably, the reason of easier getting those cancers. And it's just not just the genes.
Okay. And you mentioned the vulnerability. I think this applies to our next question as well. Are those who are obese at a higher risk of COVID-19? Is there any correlation we can find during this pandemic that those who are obese may be at risk of experiencing a more severe, having more severe experience of COVID-19? Is there anything you can shed light on there?
Now, what we know is very recently that they looked at, because we saw that from the ones who are dying from corona, there are more people with obesity. If you look at people who are coming on the intensive care, the possibility to survive there is the same if you are obese or not obese. But the chance that you get the corona is much higher if you are obese, because you are more vulnerable.
Okay, that's great to, of course, understand at a time like this, where those at higher risk should obviously be as cautious as possible.
Yes.
We have a next question, which actually crossed my mind during your presentation. So I'm very happy that we can address this. Under which circumstances would somebody want to reverse a gastric sleeve? You mentioned that it's not reversible. So I think that triggered what is the scenario in which somebody would want to do that?
Now, sometimes you have to change, you cannot not reverse it, but you can change it. For instance, what I told, if you have a sleeve and you have this reflux that the acid of your stomach is coming into your esophagus, then you can change this sleeve to a gastric bypass, and then you solve the problem of the reflux. But you cannot get back to normal. That's impossible, because you cannot put back a stomach again.
Right. So most of the cases where somebody would want to alter that decision is based on the side effects, if they're uncomfortable with the side effects.
Yes, if the side effects, you can change it to a different operation, most of the time a gastric bypass. If your weight is a problem, then it's better to look, then you have two things you have to look at. Because if people with a sleeve and they eat a lot, the sleeve really expands again. And then it can really become big again. So what people sometimes do, they call it a re-sleeve, then make it small again. That's possible. But if the sleeve is still small and still you have a lot of overweight, then the last, or one of the last things I told is satiety. Then you add, that calls malnutrition, that you do not take up all the food from you digest with your sleeve, and that improves the weight again.
Okay, great. Back to genetics with the next question. Is obesity genetic? Can we say that if a parent or grandparent is obese, that would be transferred down?
Yes, it's very genetic. And if you look at genetic, people always, and I always thought about one of the genes. But you have also, it's called the epigenetics, and that means if a gene you have is working or not working, it's on or off. And actually, the mother and the father, they give this epigenetic. So if you are always hungry and you want to eat a lot, and you are overweight and you eat a lot, and you are getting pregnant, you will give this to your child. So yes, the genes, the genetics, so the transfer of how you are and how you are standing in your life, you transfer it to your child. That is for sure.
Okay, well, that's very helpful and sheds a lot of light. I think the next question is a follow-up on the question about BMI. Is body fat percentage a better indicator than BMI? What would you say?
It's about a little bit the same, I think. So the problem with the fat percentage, it's difficult to measure. So if we have a lot of weight scales and they give you the body fat, but this is really not so accurate, because it depends a lot in how is the contact with your hands and your feet. And so the measurement is not so accurate, as you get very nice numbers, but those numbers are not accurate. So if you want to measure it accurate, you have to do a very invasive method to do a scan or whatever, which is expensive and not actually necessary.
Okay, wow, that's interesting. I hadn't been aware of that. I think we'll take one last question, Dr. Ignace. And this is also, I believe, one of the points you had mentioned about the hunger hormone in your presentation. How do I know if my hunger hormone is in regular levels? I think this is about your point of the endocrine hormones. Is there any test or any assessment that one can do to know if they fall in the normal category?
No, actually, we do not do this regularly. So what we can do nowadays is, if you get more hungry sometime after the operation, we now have the possibilities with new medicines to look if you can reduce the feeling of hunger with the medicine.
Okay.
So, and that's GLP-1. So this is also used in diabetes patients. And that's actually coming now, that we have combination of an operation and medicine to help the people who still have this feeling of hunger after the operation.
Okay, so there isn't a way that we would address the hormone. It's more about relieving the symptom.
Yes, and of course in studies, people check the hormones actually, but those are very pricey thing. So we do not do it with all the persons, but you can check it if you want to, yes.
Okay, great. Well, thank you so much for the helpful Q&A session. I think this was really great. I'd love to ask you, Dr. Ignace, do you have a closing message for our viewers today?
Now, I would ask everyone, if you think this is interesting, you get more detail, and please join our website at curo.com.
Okay, great. I will definitely link that in the description box below for anyone who would like to follow that website and connect with Dr. Ignace and the team, of course. A big thank you to Dr. Ignace for being here with us today. Thank you so much. It was such an insightful session. And thank you to everyone who submitted their questions, everyone who logged into the webinar today. We hope you gained some interesting insight from today's discussion. If you'd like to see more of these videos, please check out and subscribe to our YouTube channel. Thank you so much, Dr. Ignace. Hope you have a great day. Wonderful session.
Thank you too. I loved the session too. Thank you.
Thank you. Bye.
Bye.